Good evening, everyone, and welcome to this unique and very special event. My name is Tony Young. I am the National Clinical Lead for Innovation at NHS England, and this week is actually my 10th anniversary of being at NHS England. I was reminded the other day, I was just a boy when I started, and there we are. And welcome to everyone who's joining us online. Lucy, how many have joined us online? 15 in a minute. Okay, that's good. So welcome to you who are joining us online. If you're online, you can type questions in the chat if you have some through the evening, and you can join us. And in the room, we're going to have an opportunity for Q&A later. So we're going to speak a little bit about the Clinical Entrepreneur Programme and then about the Dementia Innovator Programme. But later in more detail, but just to set the scene, NHS England now 8 years ago took the decision to support and establish an entrepreneur programme in healthcare in the NHS. And I recall when I pitched this, everyone laughed. And they didn't laugh because I'm a comedian, they just laughed because it was impossible. The National Health Service was never going to become entrepreneurial. It was the opposite of that, in fact. And here we are 8 years later, and we are now the most entrepreneurial healthcare system on the planet. And the Clinical Entrepreneur Programme has now supported over 1,300 staff working in the NHS to gain commercial skills, knowledge and experience to help us transform healthcare. Between them, they've started up over 500 companies now, benefiting over 160 million patients and professionals through their innovations, raising now north of £1 billion between them, and creating 7% of the UK life science industry from scratch in 7 years. We're just in year 8 now, quite remarkable. And we've had a number of partnerships over the years. Our partnership with Crisis, and we've got some of our Crisis entrepreneurs here. I can see them in the audience. And how can you work with people with different lived experiences and learn from entrepreneurship about how we could take a different approach, how we could learn things differently? And you're going to see lots of examples of that this evening. But when I was approached by the Alzheimer Society last year, and we had a conversation about, can we do something new with the great challenge we've got in dementia? And kind of that's why we're here today now, to launch this new Dementia Innovators Programme. So I'm not going to say any more because we've got Simon Lord here, who is the lead for innovation at the Alzheimer Society. So Simon, do you want to come forward and say a few words for us?
Sure thing. Thank you, Tony. Yeah, welcome to everyone here. Obviously, everyone online as well. I'm Simon Lord, as you heard, Head of Innovation at Alzheimer's Society. We're the biggest dementia charity in the UK, and I'm here to talk to you about the importance of innovating in dementia. So I just need to get the clicker. There we go. The first thing in terms of the importance of innovation in dementia is effectively the size of the challenge. So that's what I'm going to be focusing on at the start. Dementia is the UK's biggest killer. It will affect 1 in 3 people born today at some point in their lifetime. Many of the million people in the UK that are currently living with dementia don't have the diagnosis. That limits their ability to interact with support services. It limits their ability to get hold of drugs that will alleviate the symptoms of their condition. 2 weeks ago, we had the really exciting news that a new drug, lecanemab, was approved for use in the UK. It's the first treatment that's been approved for use that has been shown to slow the decline of thinking skills and memory loss. And that's obviously incredibly exciting, but it is for a relatively modest period of time. And it comes with a set of side effects. Alzheimer's disease is the most common cause of dementia. And while that approval is exciting, it wasn't approved for use within the NHS. So it's a kind of very positive first step towards us having a robust, effective and affordable treatment for Alzheimer's disease, but it's nowhere near a cure. And there are over 100 types of dementia. We're still some way from being able to treat that most common one. We're much further away from being able to treat others. All this time, dementia incidence is increasing. So 1 million people live with dementia in the UK now. By 2040, we expect that to be somewhere between 1.4 and 1.7 million. At Alzheimer Society, our mission is to provide help for people living with dementia today and to provide hope for the future. And in order to do this, we effectively have these kind of 4 big strands. The first is to keep pushing the research agenda. So we bring researchers in to the dementia space. We fund a huge amount of research that is so that in decades' time, we can take the biggest killer in the UK and consider it a treatable condition. We provide direct help through our services offer, supporting people affected by dementia to come to terms with their diagnosis and to continue to take part in meaningful activities. But we know that care services are stretched. We know that the NHS is under pressure. And while there are no effective disease-modifying treatments, we know that effectively our service offer can only do so much, given that people need support often throughout the day and night. Because of this, we have a dedicated influencing team. That influencing team is kind of focused on making dementia a priority for local decision makers, for national decision makers, and they kind of really focus on helping to address the system-wide challenges when it comes to dementia, and make sure that it's front of mind for people who have the power to make change. And crucially, Alzheimer Society funds innovation, which is my team. And the innovation team is working to ensure that there's a product or solution for every person living with or affected by dementia in the UK. And if that sounds like a relatively large challenge, welcome to my world. We have been working on this for 5 years now as a program. And I think it's fair to say that we've kind of understand that there are no shortage of targets for innovation in dementia. So we know from working really closely with people living with a diagnosis that they need assistance of all kinds for daily living challenges, whether in managing money, retaining independence, avoiding unnecessary hospitalization. The list is endless, but it boils down to helping people to continue to do the things that they love, continue to engage meaningfully with the people around them, and continue to do the things that make life worth living. We know that their support networks need assurance and they need reassurance. They need assistance and respite. And then there are the huge system challenges. So only around 2/3 of people with dementia are currently diagnosed. There are equipment shortages that mean that getting people diagnosed isn't simple. It's very often, even if you get a diagnosis, not timely or specific in a way that you will actually benefit from drugs once they are developed, that need to know kind of that someone is at a specific stage of a specific dementia. And then there are kind of huge challenges around the infrastructure to deliver drugs once they are approved. And then, of course, there's the kind of entire aging population and kind of pressure on the health and social care system that we already know about. So our team has been addressing those challenges by investing in the best new ideas that could transform the lives of people affected by dementia through our Accelerator programme. The Accelerator has supported 17 entrepreneurs, 12 of which have products at market currently, and more of the previous partners will be getting to market in the next 12 months. The products have reached at least 70,000 people affected by dementia so far, and that number is growing rapidly year on year as these businesses mature. And we've brought kind of money into the dementia space, and I think it's worth really emphasizing that there isn't a real ecosystem around developing new dementia tech, and there's certainly not a great deal of investment in it. So this is kind of crucial work being built from the ground up, so that we have solutions that provide support when and where it's needed, and where service officers can't always reach. We've also developed and funded, alongside Innovate UK, the Longitude Prize on Dementia, which is a £4.4 million challenge prize. That is designed to bring cutting-edge technologies like AI and machine learning to the problem of living well, independently, and continuing to engage in meaningful activities. That's a further 24 teams that have been funded Up to this point, Challenge Prize will continue until February 2026, when we'll have an eventual winner. And the 5 finalists for the prize will be announced on the 8th of October, so keep an eye out for that. And then just to give you kind of a sense of the solutions that we've invested in up to this point, and I'm happy to say that 2 of the founders of these companies are actually in the room with us today. But we have Jelly Drops, hydrating sweets to keep people out of hospital with dementia-related dehydration. We've got a fantastic hearing training app called Ear Gym, with effectively helping people living with dementia to remain sociable, socially active, and potentially playing a preventative role, because hearing loss is one of the modifiable risk factors around dementia. We've got Smart Socks by Milbotics, designed to detect distress in people with later stage dementia well before it becomes evident and alert caregivers to intervene. And then we've got money management products like Sibstar, a prepaid debit card designed with additional protections to help people with a dementia diagnosis retain their independence while remaining safe. And that's amongst like a bunch of others. So Pod Roller revolutionizing bed bathing with their product, and Hug, which is perhaps the simplest thing we've funded, is a soft comforter for people with late stage dementia, which has been shown to be really, really effective in terms of increasing people's well-being. So many of these products, not all of them, I should say, but many of these products were just ideas when they came to us, and now they exist. They're directly helping people living with dementia. But we know we still need to do like much, much more. There's a wealth of expertise around dementia. Not enough of it translates into new products and solutions. There's a huge amount of investment in health tech, but very, very little investment in dementia. And that's despite the fact that dementia is the biggest health and social care challenge of our time. And that's why we are positioning ourselves as effectively kind of end-to-end innovation support in the dementia space. So we have a Catalyst program that's designed to seek out the biggest challenges within dementia and to effectively kind of bring new entrepreneurs into the space by inspiring them to get involved, to start looking at our programs. We've got Launchpad, which is new and will focus on early stage ideas. Launchpad is targeted at researchers in particular, and will provide business support, product development, and testing opportunities around the best implementable research so we can get tangible commercial propositions out the back of them. We're continuing to run our accelerator program to provide much needed investment and direct support from our team to get the best ideas that are close to market over the line, and make them a reality so that people can use them. And you might have spotted a gap at the end of the spectrum at scale, but we're beginning to target other investors, people who've invested in health tech before, people who invested in some dementia products before, to bring them into a kind of new funding ecosystem, which dementia innovation currently lacks, to ensure that we get better support in scaling new products and solutions. And now I'm thrilled that we're partnering with effectively the best in the business, the NHS Clinical Entrepreneur Programme team, to extend our support to a bespoke dementia-related cohort that will benefit from both this fantastic program set, as well as our expertise and access to people affected by dementia. So the cohort that's launching today, the Dementia Innovators program, will take people with ideas based on deep, professional, often frontline experience, and help them make them a reality, transforming clinical and non-clinical health and social care professionals into entrepreneurs. All of these initiatives together will supercharge the impact that we're having. So we're moving from supporting about 40 products in the last 5 years to supporting at least 20 new dementia interventions annually. The size of the challenge in dementia is vast, as we've said, but we really believe that innovation can play like a key role in the solution. So I know Tony and Dr. Tamsin, Holland Brown will be taking you through the new program in more detail in a minute. So I'll just finish by encouraging you, if you have a great idea, to look at the Dementia Innovators program, to look at our Launchpad and our Accelerator program, which are also both launching for applications in October. See where you might best fit. If you need help, reach out to our team. If your idea could change the lives of people living with dementia, we really want to be on that journey with you. So thank you very much, and I'll hand back over.
Brilliant. Thanks very much. Yeah, great. Right, Tamsin, would you like to come up and join me at the front? So, would you like to introduce yourself, Tamsin, to everyone?
Hi, I'm Tamsin. I work as a paediatrician in Cambridge, but I also I've been on the Clinical Entrepreneur Programme myself a few years ago, but have joined the team to help deliver it, which has been a complete joy. And it's very important to members of our team because some of us have experience of having family members with Alzheimer's. And so we know how important it is to address this on a personal level as well as on a professional level that Simon touched on about how important it is that dementia tech is considered. And it actually aligns with a lot of UK priorities as well as World Health Organization priorities, which is World Health Organization has just launched Equip for Equity, which is about participation and inclusion. And so we're incredibly proud to support innovators in this area. And this bit is to tell you about the actual Dementia Innovators programme. Of course, it's this wonderful collaboration between the Alzheimer's Society and SEP to bring the skills and the knowledge from both sides to be able to really equip innovators to be able to not only get their innovations out there, but to get to the point where they can scale. I know Lucy's got another slide. I want to say a really big thank you to Lucy, who has worked really hard to make this happen on this team.
We'll all bring our own stories to this, and we're going to hear from Eric Meeson in a moment, in about 20 minutes time. He's a volunteer for the Alzheimer's Society, but also with real lived experience dementia, and many of us it's touched in our own lives. And I was just reminded as you were talking about it, and Simon saying how common it is. From the age of 8 until I was around 12, I used to visit my grandmother as dementia gradually worsened. And for the last 2 years, that was in a psychiatric hospital. We used to have large psychiatric hospitals, and that's what you did with patients who had end-stage dementia. This was in the 1980s. And I used to go and visit Tooting Bec Hospital in South London. Every Sunday afternoon, that is what we would do for 2 years. And I gradually saw the change in my grandmother. That's a big impact on you when people who have big roles in your life do that. But we don't do that anymore, do we? We've changed from that mass hospitalisation to care in the community, and technology and new care pathways, looking after people in different ways. Prevention, I was talking about that earlier. Why does it all have to be medications that will treat an end-stage disease? Can we do things that are preventative, and what can we do, and how can we do that? So that's why I was so delighted when this opportunity came up to work with the Alzheimer's Society and to learn what we've learned from the Entrepreneur Programme. So Tamsin, do you want to take us through that now? And then we'll also compare and contrast it a little bit to the Entrepreneur Programme, because there's going to be a kind of an overlap.
Yeah, so we're really pleased that this Innovators programme is just about to launch. That'd be great, Lucy. And we are actually the aim is to support professionals within the NHS and also outside the NHS. And it's for innovations that improve the life of people with lived experience of dementia. And we want to be able to allow innovators to access the mentorship, the community, the healthcare professionals that we're able to provide on SEP, and also all of that expertise from the Alzheimer's Society. Thank you, Lucy. And we are very keen that everybody feels that they can contribute to this or apply. So especially people in your networks who you know, it's care home staff and nurses who are involved in dementia care. We're looking at social care staff and everyone from opticians to podiatrists who might be involved in dementia care. So we're keen to hear from everybody, and we've noticed on the Clinical Entrepreneur Programme, as we've been enabled to widen the participation in that programme, how rich it becomes from having that multidisciplinary team. So we're keen to be able to encourage people to apply from everywhere. And the only thing is that they need to be UK based. Thanks, Lucy. Great. And the offer is both from SET and also from the Alzheimer Society. We run education days which are known as pit stops because Tony was explaining that it's like racing around a track in the NHS, and then you need to stop and have a pit stop and get some fuel, and then you can keep going. So we call them pit stops. They're networking events. They're important for education and to connect people together. We have a really impressive community because it turns out that people with innovations don't just do innovations, but they also become leaders in their field. And so now we'll hear from people today who have done exactly that. The mentoring is very impressive. Again, we have people who give their time freely, high net worth individuals and high and important individuals within the NHS ecosystem. And we want people to have international and national opportunities and chances for industry collaboration. The team here have also set up an online community, which we are enabling people to have a kind of private way to connect with each other.
No, you carry on. You're doing a great job.
And so it opens on the 1st of October, which is really soon, and finishes right at the end of October. And we are encouraging people within everyone's networks to apply on the website. We will run events to help people anyway with the application process, but the team are really open to this being something where people might need to connect to the team first and explain what's going on, and that's fine. We appreciate this is the first time this is done. It's a pilot, so we want to learn as much as want to get it all right. So we're keen to have that connection and communication with people if they feel they need it through the application process.
Okay, thanks, Tamsin. So that all sounds fine, but we started, I don't like starting this way, but I decided to let Tamsin go on that because that starts with the solution. But before you have a solution, you have to understand the problem and the challenge we're facing. Simon set that a bit for us earlier, but at NHS England, who are the largest commissioner of healthcare in the world, we're the largest purchaser of healthcare in the world, we have a number of challenges and issues we're facing. We have a new government that have come in. They are bringing new thinking and new action to what we're doing and challenging us. Lord Darcy has been asked to undertake a review of the NHS. That's going to be published in the autumn, possibly this month, if not next month, it will be. And then we have a 10-year plan at the moment at school that is going to be published in the spring. And all sorts of things like this can help feed into that. Now, I'm not going to predict what's in those reports. They'll be when they're published, but everyone is talking about prevention. Everyone is talking about technology and how we harness the benefits of that to change the paradigm on healthcare, just like I was talking about earlier with my grandmother. That's all we could do in the 1980s, put you in an end stage, psychiatric hospital. There were dozens of them literally across the country with wards. I recall the place. It was huge, the number of wards they had. We don't have that anymore. We deal with it differently. We need to unlock our population. We need to unlock our professionals, our families, and our carers to do this in a different way. So it all sounds great, but the NHS in England is facing 6 core challenges at the moment. Number one is our workforce. We have about 1.4 million employees in the NHS and a 10% vacancy rate. It's really hard. We're not going to magic up another 100,000 trained clinicians, support staff, others from anywhere. We have to do things differently. How can we support our workforce? And how can we help take away those routine, repetitive tasks, low intellectual value, but that you just need a human to do them? Well, that's where we can get machines to help us. So number one is the workforce. The pandemic had them on their knees, and it's been really, really tough after that because of all the other challenges we face, because that brings us to number two, which is the waiting list, which is reboot and recovery. Over 7, moving towards 8 million people now on a waiting list. People come to harm on waiting lists. We have to deal with it. We can't just leave people on them. We've got to take action to get them off. And so that's an absolute priority for NHS England to tackle that and deal with that. Number 3, one of the big ones, health inequalities. For too long, we've just done things. Industry have produced a new medication or a new piece of research or a new piece of technology, and we've just taken it up, just thinking that it affects everyone equally. But actually, it may not. It may not apply to someone whose first language isn't English, who can't understand that. Or maybe someone who's got dementia and the pill pack you've given them, they can't understand how to use. But we still give you the pill pack because that's the only thing we can give you. Well, that's not right or fair or equal. And we have a great programme in that, led by my colleague Bola Awolabi at NHS England. And we're starting to make real inroads. So health inequalities is number 3. Number 4 is so important that we can't ignore it. We were the first healthcare system in the world to produce a policy around net zero. The environmental crisis we're facing is huge, and the NHS contributes 4% of the carbon footprint of the United Kingdom. We've said we'll get to net zero by 2040 and 2045 in our supply chains. We have to do that. So how can we innovate in dementia and also help us reach our net zero? What can we do differently in that? So net zero was number 4. Number 5 is what I call the long-term plan, as it was before, soon to become the 10-year plan, which is how do we have excellent healthcare from the cradle right through to a healthy, active, independent old age. That's what we want. How do we get serious about prevention? That's our 5th priority. And the 6th one, sometimes people put it first, but I put it last, but it is still as important, which is around financial balance. We can't keep just spending more and putting more money on it. It's not possible. I recall when I first started visiting the United States around 10 years ago, and the American healthcare spend was at something like $1 trillion, and a third of that served no useful purpose. And they said it's going to outgrow the Department of Defense. It can't get bigger and more than this. I think it's up to $3.5, $4 trillion now, and it just keeps growing. I understand that it can't go on forever. We can't just spend more. We've got to do things differently, but we also have to do different things. We can't just more people. We'll pay lower wages. That's what will sort it out. That's not the solution. We need to use technology. We need to do different things. So those are the 6 priorities at NHS England. We can't do this on our own. They're great people, my colleagues at NHS England. They're really want to help us transform healthcare, but we have to bring everyone to the centre as we do this. We have our patient innovators, bringing people with lived experience of dementia and an experience like the Alzheimer Society. I was so impressed, Simon. I've known Jelly Drops for a while, actually, but so impressed with. Just imagine what that slide's going to look like in a couple of years after we've had this lot that go on it. I mean, it's going to be full. It's just. I was inspired by it. I can't wait to get some of our new products and things up there that we'll get, because I wouldn't have come up with many of those, not at all. and there are all sorts of, and it doesn't have to be a unicorn and big multi-billion-dollar valuation. It could be something very simple. And I love that little teddy that you cuddle that gives you reassurance. I really love that. But there are also some features of innovations that are taken up nationally, and scale. Scale was one of the things you spoke about, Simon, that was really important. And it was my last boss, Tim Ferris, our Director of Transformation at NHS England, that highlighted to me these 5 core themes that innovations have that scale successfully. Firstly, they meet a national priority. Okay? I would say dementia fits into that. 1 million or so people, the largest impact, I think you said, Simon, on the NHS from a social care perspective. So meets a national priority, it does that. Number 2, it must reduce steps in a care pathway. Making it longer and more complex doesn't work. Things that scale reduce steps in a care pathway. Number 3 is it must be slippery. By that, I mean it must be easy to adopt. It must just slide into the process, whether that's healthcare staff in the NHS or social care staff, just are able to put it into their daily practice. It doesn't make it difficult. It just slips in easily. Okay. Number 4 is in-year cash release. Now, this government may change it, but previous governments haven't done. Every year, it's an annual budgeting cycle. And for innovators, you're going to hear from some of our innovators later in the room. It all has to be done in year. Carrying on to next year, it doesn't happen. It's all clawed back to the centre, and then other deficits are dealt with in different departments. So if you want to get an innovation to work, you have to show how you can achieve in-year cash release. And the last one, the 5th point, is real-world evidence. So we're moving away from randomized controlled trials as the gold standard for everything. They can work really well and have worked really well, particularly in the pharma industry, to show us around medications. For digital, well, you get version 1.1, 1.2. For AI that changes every time a new piece of data that gets fed into the algorithm, how can you keep up with that? How can you? So real world evidence from use in patients with data feeding back all the time is one of the features of innovations that are scaled nationally. They're scaled nationally in this country. There's a great chance they'll start to scale across the world. So those are our 6 priorities, and those are the 5 features of things we look for at NHS England when we're looking at something to take it forward. So it might be something very simple for the Dementia Innovators Programme. It might be, I'm not expecting someone to come up with some new blockbusting drug, but I don't want to rule that out. We've got clinical entrepreneurs looking at genomic screens, and then features that might affect that, and how you can reduce all sorts of things from inflammation and other things. So, but we have the connections at NHS England. I can go and speak to Simon at the Outside Society. I can go and speak to our national clinical directors for dementia or older people. I can go and speak to the medical director of the NHS. I can go and speak to the Secretary of State at the Department of Health. I can go and speak to leaders in industry. I can go and speak to leaders in other countries, from healthcare systems, from industry to funders and investors, to connect you with them. Now, this program isn't going to be, it's not called the Dementia Spoon Feeding Innovators Programme. We don't stick you in high chairs and infantilize you like toddlers and go along in a row and feed you entrepreneurship. That's, if you think it's that, you're in the wrong place. There's great food afterwards and you can stay for that, but you need a different program, okay? You will get out of this program as much as you put into it. And challenge us, hold us. How can we help you? How can we connect you? We will give you honest feedback. And you're going to hear from some of our innovators shortly about their journeys in this space. And they'll speak to you about the power of the network, bringing like-minded people together, so you can leapfrog those things. You don't have to make the same mistakes. Meet other people who are working. Where did you raise your funding? How did you overcome this problem? How did you find a chief technology officer? Do I need a chief technology officer? Do I need a chief finance officer? What do I do about raising funding? I think we're about to run out on co-cost. What do I do? How do I write a grant application? Who's going to help me trial this problem? Who's going to help me take it through regulatory? I have no idea. We can help you with all those things. That's what we do. Okay. So Tamsin, do you want to, I don't know how we are at time, sorry, I wasn't looking at the clock. I think we're okay. Do you want to have any closing thoughts or remarks on this new programme and what your advice would be to people?
I think it opens a new space for the Clinical Entrepreneur Programme to be able to connect with charities in this way, and charities sit in a very important space in innovation because they actually provide this type of access to people, which you can't just go straight to investors and start raising. To have that connection to patients, you need to think about participation and inclusion in your design, and you need to understand where charities are sitting, and charities are able to be very innovative and support people in a way that there maybe isn't space for them to do in other ways. So I think this one, being able to support people within the NHS and outside the NHS, so UK based, to provide access to people in a very wide span of different specialties around dementia. I think it's probably really exciting. I think it's exciting for the UK. I think other international partners are interested in what we're doing here. And this is a pilot, so it's important that the first cohort are well supported and that we learn really fast and that we are able to provide that knowledge for how this type of collaboration can work. And I think it's exciting for the Clinical Entrepreneur Programme to be able to learn in this type of way. And it's really hopeful for people who are touched by Alzheimer's. I think it's great to see. I mean, the innovators that you'll hear from now are remarkable, and thank goodness they're here because they are working endlessly to be able to bring the type of innovation that will improve people's lives. And that's what it's all about, isn't it? It's just that what we can do to improve things for others. And although people might have brilliant ideas which can affect the 10 patients in front of them, we want to be able to do more than that. And thank you very much to the Alzheimer's Society for your knowledge and expertise in this innovation area, which I think we're all known for. So thanks.
Brilliant, thank you very much, Tamsin. So what I'm going to do now is I'm going to introduce you briefly to Eric Deason. And Eric, I think I said your name wrong earlier, so I think I called you Eric Meeson. For some reason, I met you and I thought Liam Neeson. Now, I don't know why I thought you were a Hollywood tough guy, but it's definitely Eric Deason. And Eric is, well, he's going to tell you a little about his journey. We have to have patients included. For too long have we designed healthcare as doctors, have designed sick care as doctors, let's call it that, and treating it. And I am committed to having patients and carers and families and communities involved in everything we do, as are NHS England. So yeah, I am so thrilled. Our entrepreneurs are amazing, but it wouldn't be amazing without you here. So I'm so thrilled. And Eric, we're in your hands for the next 10 minutes or so. Why don't you tell us a little bit about your story?
Thank you. I hope I can manage without this. Can I manage without that?
I've got online, I think they'll need to hear you.
Oh, okay. Right. Hello, everybody that's here, and hello, everybody that's online. Hope everyone can hear me. My name's Eric. I'm from Birmingham. I've been working with Alzheimer's Society for just over 10, 11, 12 years, something like that now. And well, this is me. What I would like to say something about is public involvement, what we call public involvement nowadays, where lay people, everybody's a lay person in some field, everybody's a lay person in the field that they're not expert in, So lay people, volunteering or otherwise, to help programs like the one we're talking about today, but all the other programs that they do. People have been doing this for centuries in law and so on. You know, justices of the peace. Oh, thank you. I wouldn't have noticed that. Thank you very much. Okay, so just a little tiny bit about me. After I retired, I started my third career, and that's full-time volunteer in public involvement. My second career, actually, I was an international consultant with UNESCO, the World Bank, things like that, going around the world, advising governments and so on. I say that because there's a feeling very widespread that volunteers aren't actually real people, aren't actually professional. And there's a barrier there in a number of contexts with which I work. In our local church, you know, the priest will say, oh, can you organise that? And of course we do it, but I don't realise it necessarily. So I'm just saying that there. So in this particular context, I joined in with the Alzheimer's Society just over 10 years ago. I see it is now. And just by Tower Bridge, we had this fantastic view of Tower Bridge every time we went to Devon House. I really miss it. Okay, but anyway, this isn't actually about myself. I'd like to start with Fred Deason, who was born in 1895. My dad. Someone else had a grandma. Now I've forgotten which of you it was now. So Fred Deason was born in 1895 in London. He was a salesman. And the important thing about him is that he had senile dementia for his final years. Senile dementia, it was called then. And his treatment wasn't to go into a hospital, mental hospital, it was to go into a lunatic asylum. That's 20 years before you know. So, you know, things have changed remarkably. Good bloke that, injured in the First World War. His brother was killed in the First World War. These things, you know, there we are. But anyway, here's me now, born a lot later, 50 years later. I used to be a teacher. And as I say, did all sorts of things after that. Alzheimer's Society volunteer since 2013. I was diagnosed with Alzheimer's, in fact, in 2012. And thank goodness I'm still going strong. I think I'm still going strong, but partly I'm going strong because of this sort of work. Keeps them mentally and physically fit, and that's absolutely great. So I don't, you know, I hope I'll go for a few more years before when some of these ideas come to fruition. So what's the difference between these two people? My dad, 50 years before myself, into a lunatic asylum. And now me still going strong with whatever support I need, whatever care I need. It's amazing the difference. And it's really good. So when I use these slides usually with the Alzheimer's Society, I'm talking about research. So the difference is research. Can't find the button. Where's it gone? Oh, stupid idiot. Thank you. Okay, so it's research that makes the difference. There are lots of other things. Research has made a huge difference in the last 40, 50 years to the treatment of dementia, and I'll come back to that. But there's all sorts of other things. Culture change, look at that. Care. People care now for people who are unwell, whether it's mentally unwell or physically unwell or dementia or whatever. And the Alzheimer's has come along and made a huge difference as well. I'll try not to press the wrong button this time. Here's what the Alzheimer's is about. Lost that thing. We vow to help end the devastation caused by dementia through support, number one, and research, number two. So this is what the Alzheimer's Society vows to do. And I'd love to vow to be able to help in that as much as I can. Notice the support. £100 million a year the Alzheimer's Society spends on supporting people living with Alzheimer's, their carers and so on. And £12 million a year on research. To me, that's the wrong way round. But of course, it's all those million people already with living with dementia, and their families and their carers and the people they work with and the people they meet all need help, need support in some way or another. The wrong button again. The cost to Britain, United Kingdom, is more than 45 billion pounds a year, and we spend in the Alzheimer Society 12 million pounds a year to try to do our best. There are other charities that spend money on that, and of course the National Health Service does so as well. But the important thing about that is my work with the Alzheimer Society, mainly in research. The Alzheimer Society is the only charity I work with, and I work with a lot of charities, that does research into care as well. And the innovation sort of approach, which is 5 years old, I think you said, Simon, is also looking at care support rather than researching into the causes of or the early diagnosis of or whatever. It's all very important. And sometimes I think 12 million pounds a year. Do you know what Cancer Research UK spends on research for a less important condition or set of conditions? 800 million pounds a year. It's something I'm always on about. Wish it was the other way around. We could do so much with that and spend a lot on care as well. I've totally lost my place by now, so let's get back to the pictures. So the Innovation Collective, which is part of the innovation section of the Alzheimer Society, has been working quite rapidly over the last few years to develop the sorts of things that we've been talking about today, to see what people need, people living with dementia, what do they need, what are they going to need, what do their carers and so on need, and try to, technology, application of knowledge, trying to work out how to help those needs. And we've all been doing that. So a number of us have been doing that for the last couple of years. I think I started about 18 months or so ago in this particular area. And the sorts of things that we do within that people like myself do are reviewing the funding bids that come in. Maybe we'll be helping with reviewing the bids that come in for this programme. Particularly thinking about the benefit to people living with dementia now and people who will later on still sadly live with dementia. The funding board as well, working with the accelerator partners. Well, Simon mentioned the accelerator programme, which is exactly what we're talking about today. People have an idea, how can we help them turn that into reality? And I've worked with a number of the products that Simon had on his slide there. Some very simple ones, some quite complex that need a lot of development and thought and redevelopment and so on and so on. But we do that willingly, and I think they appreciate that. So public involvement in the Innovation Collective is fantastic. Public involvement in this programme, wherever it is, would be fantastic as well. Having us helping people think about what the real needs are rather than guessing is great, I think. So I'll be around after the end of the meeting. There is a Q&A panel, but it seems to keep changing every time I see. So I'm not sure if I'll be in that or not. But anyway, for a little while afterwards, I should be there too. So thanks very much, folks. Good luck. Hope this programme goes well.
Eric, am I allowed to? Eric, can I just ask you? Am I allowed to ask you a question?
How old? You interviewed me already.
How old are you?
I'm older than Biden.
Oh, that's right. And you were born in America, so you can run for president.
Saving money, I get if I have to mention about. Probably less.
Well, that was amazing. Thank you so much, and we'll definitely get you up for the little Q&A panel at the end. Come and see. Right. Well, just inspiring. How brave to step forward and speak to people, clinicians and people working in the industry and startup space to come and do that. That was amazing. I felt humbled that I took a little photo of you doing that. That was lovely. Thank you so much. Right, now we're on to the exciting bit. Okay, I always get excited when I hear about people sharing their stories and sharing their dreams, sharing why they are passionate and committed and driven. You know, and when people share their values with you and their dreams and what they're doing, it's a real privileged thing. And it happens to me hundreds of times a year because of the entrepreneur program. And so you're in for a real treat now. Now, normally I give them just 60 seconds, but this evening we've given them a bit longer. They're all going, oh no, not 60 seconds. They told me 10 minutes. No, we've given them a little bit longer this evening because their journeys are inspiring and authentic. Lived experience from the front line in healthcare and what they're doing about it. And they're all astounding in different ways, all very different. Boy, are you in for a treat now. So I'm going to go in order. First up is Deb Gompers. Deb, I will time you for 10 minutes and I'll just give you a little flag, but I'm not going to be too strict.
It was 15 minutes initially.
Well, I think you're just being entrepreneurial.
No, it was 15 minutes initially, so I'm going to speak at treble speed.
You can have a little bit of leeway.
Hi everybody, my name's Deb Gompers and I'm a GP with a special interest in older people's care. Initially, I worked in hospitals and I was a GP partner for 16 years, and for the last 8 years I've been doing this new model of care. Tonight I'm going to talk to you about Show Me Your Meds, and I'm going to talk to you about the 3 phases of that. I'm going to talk to you a little bit about what the Clinical Entrepreneur Scheme has offered me and enabled me to do. So just a brief bit of background about how I work, because that's important to understand the project that I'm doing. So I am employed by our hospital trust, but I am very much working in primary care. I actually say that I work for the population now, not for primary care. So I work with district nurses, rehab teams, I work with volunteers, I work with the Alzheimer Society, I work with Royal Mail Health, I work with GPs, secondary care, discharge to assess. I work with everybody, families, carers, people, patients, people stroke patients, because we're not supposed to call them patients, new patients anymore. So I work with everybody. We work smarter by working together. We don't do referral processes to save time. We talk to each other. We put the person at the centre of what we do with shared decision making and what matters most to them. So that just gives you an idea of what we do. So the person is at the centre, and people don't always fit into the pathways that we've developed. So actually, I'm called a complex care GP, but I'd like to turn that around to say the system is complex, not the person. How do we make it simple for them? So, should have gone on to that initially. This is my problem. So I'm starting with the problem, to please Tony. This is common. This is not uncommon. And actually, this is quite minimal for what I see. I will find 2 years of insulin pens in people's homes. I can find a year of inhalers in people's fridges. 3 to 6 months of medication in people's home is not uncommon. So I'm ticking boxes here for net zero. I'm ticking boxes for smarter working, because how we tackle this is we ask our community colleagues, who I work with and sit in the same space as them, to simply ask to look at people's medication when they go into someone's homes. And that's simple. No extra resources, it takes 30 seconds, and then we work out why people aren't taking their medication. So it's individualised care, it's preventative, and it's environmental and cost saving for the NHS. What I also want to say is that the people who we identified initially had all had medication reviews by their GP surgeries, and a third of them in the home, a third of them on the phone, and a third of them in the surgery that had not picked up this problem. So if you say to someone, are you taking your medicines? They'll go, yeah. They don't want to upset GPs, they don't want to upset prescribers. You turn the box over, it's a year out of date. So you can then start to ask another question. So part 1, I was doing a population health fellowship, and we looked at 160 people, 1 in 4 people were taking their medication as prescribed. So we identified over 1,000 months of prescriptions in people's homes. This is an underestimate. So this is a snapshot. This is what we counted. It's massively more than that. The cost We costed it and it came out at about £11,000, which doesn't sound very much, but if you scale this up to 1,250 primary care networks across the country, that's 1 million prescription items in 3 months with no extra resources, £13 million of wasted medicines. That's quite large. And the carbon emissions is massive, but I'm not going to go into the exact amount of carbon emissions. So this was our first study. We stopped counting because it's such a big problem. It's massive. These people are going in and out of hospital. These people aren't taking water tablets because they have to get up and go to the toilet. They don't like taking them. So the district nurses are going in, dressing their legs, they go to hospital, fluids offloaded, they come back, they're still not taking their tablets. So I mentioned holistic care. It's very much about the person. It's shared decision making. It's talking to people. What do you want to take? Can you take it? Are you getting side effects? Or is it that you're not processing and can't manage to take those tablets without support? Do we have to change the regime? So we changed 50% of the regimes to make it once a day medication. That actually helps social care as well with the care packages. A third of the people had a new diagnosis of cognitive impairment that we identified, so we could then be preventative and get these people up, moving, exercising, challenging their brains, keeping their brains active, so we can prevent that progression to dementia. Clinical Entrepreneur Scheme then came along in my life, and it was a little bit of a competition with my husband who would get accepted. And I'll tell you more about the story of that day when another time of who got the email first, and oh my gosh, that was a little bit interesting. So what have I learned from the Clinical Entrepreneur Scheme? So I'm going to give you 3 Ps. Pitching, so important. And I think initially you think, gosh, why am I pitching? The 60-second pitch, even the 30-second pitch is how you get your second conversation. And it is about that second conversation with people. So that brings me to number 2P, people, tribe, networking. It's amazing. It really is. Without the power of this group, I wouldn't be where I am at all. And the 3rd P is permission. I think the Clinical Entrepreneur Scheme has given me permission to do this because I can now stand up with confidence and go, I'm a clinical entrepreneur. It's okay. I'm making changes. That's all right. I can do that. I'm allowed to do that. And there is a 4th one, but I couldn't think of a P for it. It's about the language that's spoken here. So people, I haven't got a business. I'm not selling anything. And I'm not a digital app or company. I'm not doing a digital thing. So that puts me in a little bit different box. I have moved on to a bit of digital stuff. I'll tell you about later. You'll be excited. But the language is really important because to make change in the NHS, you have to speak a language. And that language is the same language that the clinical entrepreneurs speak. So even within the health service, I need that language. And it took me a while to realise that, to be honest. And the first time I came, I was a little bit like, oh, I'm not sure why I'm here. But actually throwing yourself into it, learning the language, proof of concept, pivot, all of that. And also it helps me to understand what my husband is saying at home because he's a clinical entrepreneur and I would have no idea what he's talking about. So the RCGP I put up there because I've done some work with the Royal College of General Practitioners around GP with extended role and frailty. So we've got that endorsed by the Royal College of GPs. So people like me, of which there's a growing group of us, feel that we have a place. And it's interesting because if you don't have a home, you don't feel that you belong. So by having that done by the RCGPs, it's great. And we are hoping to work more with the RCGPs and have a narrative around that. I'm looking at Adrian a little bit, he's not looking at me, who's here, who works with the RCGP. So networking has been fantastic. Part 2, Healthier Futures Action Fund. Who'd have thought I'd have got a grant for this? But I did with Greener NHS because Greener NHS was up and coming. And Greener NHS was just developing. They had money, so you have to be smart with where you go. So Tony Avery, National Director for Prescribing, said, go and replicate it. Show me it's not just you. So I did. I went to a retirement village in Bristol, talked to the health advisor, and we replicated it. We got the carers in the retirement village who looked after a third of the population, about 100 people, to do this. And we picked up about 10% of people not taking their medication. Sorted that out. But then it made us think, where else could we go? What else can we do? We don't really want to just pick up waste. We want to get upstream. We want to talk to people. So we did some talks in their village hall called Me, My Medicines and the Environment. And we talked about the impact. We gave them permission to talk to their prescribers so that they could challenge whoever was prescribing to say, could I do it differently? Could I perhaps do a social intervention? Is it blue prescribing? Is it green prescribing? Can I do something different? Do I need to take a medicine? And the other population we found at this point was the hospital wards. So the ready-to-go wards, medically optimised wards, we didn't feel comfortable with 80% of people on discharge that they could take their medicines as prescribed. In the retirement village, we started to collect medicines that weren't being used so that we could dispose of them correctly. And 300 people in the retirement village, compared to those are the figures from the 30,000 primary care network that we did, we collected 550 months of prescriptions in 6 weeks. So if you count that up to 12 weeks, the same as the top one, that's as much waste in 300 people by having those conversations with people. The left picture is BMA House. So back to the Clinical Entrepreneur Scheme, I had a mentor. I have to say, before the Clinical Entrepreneur Scheme, I had never talked in front of people at all. I'd never got up, I'd never done it. And I said I couldn't. And that wasn't the first talk I went to. That was BMA House. There were about 1,000 people watching that talk, not all in the space, online as well. The first one I did was the British Geriatric Society. I think there were 200 in the room and 200 people online. And I actually quite enjoyed it, I have to say. And that was thanks to my mentor for getting me up there and for helping me to do the talk I wanted to do. The other picture, Pharmacy Congress. I'm going to be really quick now, treble speed. I see my work being shown at Pharmacy Congress. Other people are doing this across the country. And I put up the Pharmacy Congress because it doesn't matter what your background is, it doesn't matter what your skills are, you can blend those skills. Everyone has skills that we can work with together. So part 3, SBRI grant, we are now spreading this across Somerset. We are linking primary care network teams with community teams. So to get them to ask to look at people's medicines in their homes. And that has brought teams together as well to work as integrated neighbourhood teams as per Claire Fuller's work, but we've been doing this for quite a long time. We've process mapped prescriptions across the flow of the hospital and primary care, and we're looking at the points that we can make the biggest difference. So one of them, just really quickly, is sending people into hospital with their medications, because some hospitals will reuse them so they're not wasted. Not all hospitals, so you have to ask. So that's a really simple thing to do. And we're also, this week, just launched our teaching resources across the trust. British Geriatric Society, I'm the Deputy Honorary Secretary. Again, I wouldn't have even thought of going for that without the Clinical Entrepreneur Scheme. So I'm a GP, second GP to do that in a group of geriatricians. So I get to look at policies and help transform care of the older people, which is fantastic. I also have to write for the agenda article every second time, which I never thought I could write either, never mind stand up in front of people. This slide should have gone before that one, sorry. Also working with Royal Mail Health. I met Royal Mail Health on this programme, and I think 4 weeks ago, I think Connor's online, who's one of the posties that we're working with, and we have launched this where posties can knock on the doors of people that they think are vulnerable. And we have an app with volunteers, and we have volunteers locally and on an app, so we can get support to people who are vulnerable, often people who will have memory problems. PGS, this is where I got to from the Clinical Entrepreneur Scheme. Doing a round table discussion with Chris Whitty, I can't tell you what a sleepless night I had before that, trying to read the policies, and we got Steve Powers in the background, but that was just fantastic. So, and that was about transforming care, and we've written that up, and that's on the internet. So what's the future for me then? Collaborative working. We're asking our pharmacy techs to do the diadem tool, which is screening for dementia in care homes. We're training them up to do that. Why not? They want to do it. They're doing the medicines reconciliation. Structured medication reviews in hospitals. Why not? Single prescribing document, one prescribing digital document across all our system is what I'm aiming for. And I think we can probably get there. That's just a summary. That's the end. And I just want to say thank you to the Clinical Entrepreneur Scheme for enabling me to do what I want to do and get where I want to get to and look after the older population. So there we go. Thank you.
Thanks so much, Dave. Just ask people and they'll go, and you get that shopping bag full of out-of-date medication. And I'm sure that people don't want to worsen our environment. And if you give them a choice, they'll make it better. And this is something I can do for my community. There's so much, and the post office thing, and it amazing, just amazing, isn't it? Wasn't it? Doesn't have to be an artificial intelligence super brain that's going to change the world, although we do have one of those coming up later. Anyway, right, next. Francis, we are in your hands. I'll be lenient, 10 minutes or so, okay?
20
Did I say 20? Now they're having taking them right.
Thank you. Jack's lying in bed. He wakes up and Sarah's at the side of his bed. Good morning, Jack. How are you, darling? Did you sleep well, pet? You're looking well this morning, love. And as she starts to help him, support him up, Jack leans up, puts his arms around her and goes to kiss her. Stop! Stop that, Jack. What are you doing? Jack's really confused. 15 minutes later, Sarah's in the car to the manager. I'm not going into that house anymore on my own. I don't know what he's going to do to me. He tried to kiss me. That's inappropriate behaviour and it has to stop. What we had is a situation where, because of the behaviour of the carer, Jack was confused about what was happening. He misidentified the carer as his wife. He responded to all of these endearing terms, pet, sweet, darling, love. Someone started to take off your clothing and he assumed they were in an intimate relationship. The consequences of that for Jack were that there was an increase in his care package. He needed 2 people to now support him with personal care because of his inappropriate behaviour. The care that was delivered to Jack was different because staff were now wary that he would do something inappropriate to them. So Jack's situation completely changed. We need to see the person with dementia beyond the label of dementia. People with dementia have the same needs as all of us. They're trying to make sense of what's happening around them in the same way that we are. But sadly, what happens is sometimes we behave in ways that actually add to their confusion. But the people that suffer from this are the people with dementia. So we do something that has a significant impact on the rest of their lives and their care. So if we can see the perspective, then we can offer support that actually increases independence and improves quality of life. And this is what we do in 6D dementia training. Quality of training is essential because it's not that that care member staff, wanted to be disrespectful towards Jack, but she didn't know how to engage with Jack. And she had no insight into the fact that it was her behaviour that actually had caused the change in his behaviour. So unless care staff are equipped with the skills and knowledge that they need in order to offer care, then we're going to get this escalation and changes in behaviour, and the people that are going to suffer are the people with dementia. But it's also going to be more costly for the health service. So what we need system-wide training, quality training, so that we can improve the quality of care and address this healthcare burden. So I've been delivering training dementia care for over 15 years. But one of the challenges is we need to be able to scale this, because whenever you're delivering training face-to-face, there's a challenge on who you can deliver that training to. But also our climate has changed. We've got staff who are really busy, and it's really difficult for an organisation to release multiple staff for training sessions. So this is why, with support from TechStart and Innovate UK, I've been able to build an online training platform. So the unique USP of 6D is that it's flexible, it's easy to access the online platform, and you can access it when and where you want. There's bite-sized modules, so it means that there's less disruption for staff. It's based on expert knowledge, which makes what seems like complex material much more simple to understand. We try and demystify the complexity of dementia, because people with dementia are just the same as me and you. We're just trying to get on with their world, but they have the added difficulty of the complexities of changes in cognitive function. So we've got practical skills, not theoretical skills, practical skills, scenario-based training, with multimedia rich modules to engage staff and help them to really better understand dementia. But also there's role-based access because everybody needs to know about dementia. So there's access for a range of people, and depending on what your job role is, then you will access different modules within the training program. So this is 6D. So what we find with dementia is that people see a label, but they don't see the person. So what we're using the acronym Please See Me, because it's to help staff to understand that these are all of the dimensions. These are the 6 dimensions of dementia that are really important to see the person. Their physical health, their life story, the environment they're in, the activity they've access to, whether they feel safe. One of the big challenges of dementia is that it can really shake your feeling of safety. And then emotional well-being. Cognition's there as well, but cognition is kind of overrides it all. It's not the first thing we look at. The first thing we look at are these other dimensions. And then with cognition as well, then we're seeing the whole person. So this is the way that we see dementia. Just to give you an example, if I am in pain, I'm going to be really grumpy. And if you try and support me to move, I'm going to resist that. So, but what happens is with people with dementia is that sometimes they can't tell me that they're in pain. So if I don't know that they're in pain, I will act in ways that actually increase that pain, which will increase their distress, and they will resist support with personal care. So we offer advice to staff to help them to recognize symptoms of pain and care for a person in a way that reduces that. Things like life story. We all have a unique life history. We've got, challenges and achievements that we've all had. But if I don't know your life's history and who you are, how can I care for you as a person? Then you just become someone I have to do something to. But if I know your life history, then I can actually care for you as an individual, and your experience of care will be much better. In terms of making sense of the world and the environment we're in, if you look at this picture, so we've got a lady who looks in the mirror. She's in her 80s, but she believes that she's in her 30s and she's gone out to work. So if I'm in my 30s and I'm going out to work, why is this person standing beside me? And why have they got a Zimmer frame as well? Because, I'm getting ready to go out to work. So, but if care staff don't understand that, they're not going to approach that lady in a way that the care is acceptable. So we have to understand that the person that we see in front of us might be living in a different time period in their life. So we need to understand that. And this lady will have no idea that she's living in a care home. So there's the challenges of that. The other thing is how we spend our day affects how we feel. So does the person with dementia have access to a range of activities that they enjoy, that they're able to do, and they can interact socially with other people? Because a lot of the times whenever people are living in care homes, they don't have access to the range of activities that actually is really stimulating and improves their quality of life. So these are the kind of things that we talk to care staff about so that we can actually improve the experience of the person. And then safety, which I think is a real key, is what happens when we don't feel safe? Well, when I don't feel safe, I want to leave the environment I'm in. I want to be with people I trust and I'm close with. So we will get referrals to our specialist team all the time. Someone wants to exit. Someone's exit seeking. They're constantly asking for their family. Well, if I'm exit seeking, it's because I don't feel safe where I am. If I'm asking for my family, it's because I don't feel safe. And I want the people I feel safe with to come and support me. So we talk to staff about some of these, how people might engage and what it might actually mean for that person. And then what support could we offer whenever they have this experience? So what we're really galloping towards really is emotional well-being, because emotional well-being is important to all of us. So if we have care staff who actually understand the person, can offer support in a way that's really respectful for that person, promotes their independence, offers them a range of activities, then we can create emotional well-being for people with dementia. But it's not just important for care staff, it's important for everywhere, because people with dementia go into shops. They access every single service within their community. So it's really important that everybody has an understanding, not only of the facts and figures about dementia, but actually what would it feel like to be living with cognitive impairment, and what can I as an individual do that might support that person and improve their quality of life. So the impact of quality training. So the impact of quality training is that it delays the move to a care home. What happens is that as dementia progresses, there are changes in behaviour, and it's changes in behaviour because the person's trying to make sense of what's going on around them, and the people who are around them are engaged in a way that increases distress. 80% of admissions to care home are because of two behaviours that carers find difficult to understand. So if we help carers to understand the behaviour, then we can delay the admission to care home. And the annual fees for a care home are 62,500 per year. So we can save significant savings if we can reduce that. And people don't want to go into care homes. They want to stay at home for as long as they possibly can. We can reduce unnecessary dementia inpatient admissions, because what happens is, with changes in behaviour, then risks tend to increase, and some will require an admission to a dementia inpatient unit for assessment. When people go into dementia inpatient units, it's very hard to get them discharged again, because what happens is that they sometimes, if they've come in from home, it's been in a crisis, and the family think we can't cope anymore, or they've come in for a care home, the care home will say, we don't want that person back again, we can't manage their care. So it's very hard to discharge someone from care homes. The weekly costs, these are 2018 costs, I couldn't find current costs, they're probably out there, but I just couldn't find them, are between 2,500 and 3,500 a year. It is not unusual for people to have a dementia inpatient admission for 6 months or a year. So a 6-month admission will cost an NHS trust 78,000. So we're talking about a lot of money. And if the staff knew how to engage with a person, we could reduce that inpatient admission. Psychotropic medications. So what happens is somebody engages in behaviour that I don't understand. What do we need? We need an antipsychotic. So we need to, provide a prescription to fix that behaviour. We don't look to ourselves to think, is there something that I might be doing that actually might reduce that distress? And we all know what the side effects are. So, side effects of the antipsychotics include increased risk of stroke and death. So it's very significant. And the fact that it's because of our behaviour is kind of quite obsessing. It's heartbreaking, really, when we kind of think about it. And then the other thing is there's, staff burden and staff stress, because what happens is if you're caring for someone and you don't understand their behaviour, your stress levels increase. And as staff stress levels increase, there's increased staff turnover, increased staff absence. But if we've got a workforce who is well trained, who understand how to engage with a person with dementia, we reduce these behaviours that were referred to as challenging. I'm nearly done, actually. We reduce these behaviours that are seen as challenging, and we also have lots of savings in terms of. Okay, so we've delivered 60 training already to an organisation, and this is what really people say about us. So they're saying, like, I've got a greater understanding of the experience of people with dementia. That's it, job done. That's what we really want. I have a greater understanding of the potential causes of behaviour that challenges me. I have a greater understanding of how to respond to behaviours that challenge, because our response to these behaviours is a complete game changer. And then I feel more confident in my ability to communicate with people with dementia. So these are all real wins for us. In terms of our specialist team training, what we find is 100%, I'm kind of very proud of that, say that they feel more confident in their ability to help colleagues to understand changes in behaviour. They're more confident in their ability to help colleagues to understand the causes, and they're more confident in their ability to help colleagues communicate with people with dementia. And which was really lovely, some of the comments from the training are, I can't wait to put this into practice, all of these new approaches, brilliant course. And just a couple more comments is that, again, it's very practical skills-based training. And I kind of put that up here, it's bragging really, but I need to brag here in the Clinical Entrepreneur Programme. I don't think it could be improved, it was brilliant. So the other thing was that we asked people to, how likely would you be to recommend this to a colleague? 9.7 out of 10. So I think the training is pretty good. But I suppose really in terms of then the Clinical Entrepreneur Programme is I couldn't have done this without the Clinical Entrepreneur Programme. Like, I was a clinical psychologist working in practice. I developed a very good training programme, which was well received, but I couldn't scale it. I didn't have the skills. I didn't even know what I needed to do to be able to scale it. So joining the programme was one of the best decisions I've made in the last few years. I've met some amazing people who have helped me think about things I wouldn't even have thought about in order to be able to kind of scale this and take it to where it is. So we're at the stage now with funding from TechStart and Innovate UK. we developed a prototype of the platform with a wireframe of the platform with the support of TechStart. And we went out to review with care homes and NHS trusts, really positive feedback with some ideas about how we change it. And now with the funding from Innovate UK, we're building the full platform. So our first customers wanted face-to-face delivery because they wanted it sooner than it was ready. So they're our pilot site now who have access to the online platform. And we've got kind of customers coming in with expressions of interest. So for me, thank you to the Clinical Entrepreneur Programme. I would absolutely not have been able to do this without you. And it's been a really amazing journey. Thank you.
Thank you. Thanks so much, Francis. Awesome. That just inspiring. Huh? Wow. Shouldn't everyone working in health and social care have that training? I never thought about it. I looked at those mirror pictures and I thought, I look in the mirror and I see that. I see that. Totally. Now you're in for a treat. So we couldn't have, so we'll go from care pathway change, something that might seem very simple, but actually very hard to do, just changing the way patients do things, to one of the world's leading examples of how you implement artificial intelligence in healthcare that doesn't just make a difference to one of those huge problems I told you about, which was our waiting list, 7 million people. It also makes a difference to the workforce. That was another one of those things. It also makes a massive difference to equality, diversity, and inclusion. It also makes a massive difference to net zero. It fits in with the long-term plan, and it saves a lot of money. Bingo. Bingo, Ben. Do you want to come forward? All 6 of NHS England's major priorities and world-leading artificial intelligence. There you are. We're in your hands. 10 minutes there.
Using one of Tony's favourite words, wow. Most importantly for Francis and for Deb, actually, I think the amazing work that you guys are doing is actually so impactful to how we deliver care. But on that sort of delivering care, I think it's also important for us to note that there are just a limited number of us. And so we really have to think about how can we use tools to expand our existing capacity. And really that's what our purpose is at Deep Medical. It's about how can we use AI to expand healthcare capacity in the purpose of today, which is to reduce the backlog, but also to drive equitable access to care. And so the way that we do that really at the moment, or starting with the problem, is about looking at what are the issues that are faced here in the UK. So 6 million people waiting for outpatient appointments, 8 million patients that miss their appointments each year, and 4 million patients who cancel their appointments under short notice, and we just don't fill those appointment slots. So Sasha's sat over there, she's part of our team. She's not very good at maths, she taught me this one. But I don't think that those two numbers are too difficult to slot in. So really, it's not a question of working harder, it's actually a question of working smarter. But actually, that's also super important, because then when you look at outcomes, we have the worst health inequalities in all of Western Europe. So the National Health Service, despite being a free access point, is failing at delivering healthcare to patients. 10 years of life expectancy difference between the richest and poorest 20%. That's unacceptable. But why is that important to what we do, right? Well, what we built is an AI system that can help us understand how patients engage through those two really easy operational points that we were mentioning. How likely is someone to miss their appointment, or how likely are they to cancel under short notice? And we do this through looking at like a myriad of different data sets. So I think firstly, it's really important to mention using ethical AI is super important, right? But what does that mean? Use the right data. So we don't touch healthcare records. We don't touch personally identifiable information. And then what we do take is a historical footprint of that patient. And we look at things like their social determinants of care. That's really important when we think about addressing those health inequalities, because it's not just about where people live, it's how their transport, what access to transport they have, how far away they are, what events are going on. And importantly, what type of work do they do? And then the other two factors are actually much more based on the hospital themselves. So the process mining that we do helps us look at the sort of 8 layers of booking team members that we have in a hospital at the moment, which book you an appointment. So how far are they booking out appointments in advance? What's the sort of cashing up rates and their data cleanliness issues? And then finally, who's the clinician? And I suppose it's never one of these factors that puts someone at risk. It's always how all of these factors are interplaying with each other that means that AI is actually a really perfect solution for this. But then there goes the solution. So what do you do? And we kind of break that into sort of 3 different main areas, which is how do we make better scheduling decisions? Really simply put, how many patients do you book every week so that you make sure you see the right number? The second is about how can we then use those profiles of risk and start to personalize the outreach that we have. So we have partners such as Cisco and Uber, so that we can start to target personalized messaging for people in ways that they understand. And also importantly, organize transport for people who can't afford to take the journey in and actually physically get them into those appointments. But today, what I'm really excited to talk to you about is actually how can we start to identify those patients where we can text them to hell, we can offer them an Uber, but actually that's the wrong thing for us to be doing. We need to think about how do we personalize care and address the long-term plan, and that's our Pathways product. And before I was a clinical entrepreneur and on this program, I was a frailty reg, and there's a really amazing consultant called Sheila O'Riordan, and she always describes this, and she says my mum, and I'll say my grandma, but she says my mum is old, she pays with her Apple Watch, my grandma is frail, and my grandfather is frail, and he walks with a Zimmer frame. He needs help. He needs a better understanding, more holistic care about how we can deliver those services for him. And then when you look at the outcomes against those patients who struggle to turn up, we see that in every single one of those core 20+5 areas that NHS England set around addressing health inequalities, if you don't turn up to your appointments, you have worse outcomes. And probably the most important one is a large study in Scotland, which showed that patients with mental health conditions and long-term conditions who missed 2 appointments had an 8 times increase in all-cause mortality for missing 2 appointments a year. So 8 times more likely to die than the same patient, same condition. So there's a larger health economic picture here as well. And when we engaged with patients who were over the age of 75, we identified that it wasn't an issue of forgetting their appointment. It wasn't an issue of needing maybe time off work or support with moving the appointment around their lives. It was actually issues of frailty. And when we looked at the data, we saw that whereas people got older and their access to healthcare goes up. And in this chart, what you're seeing is the most deprived population and the least deprived. So you're seeing 2 things. If you're more deprived, you're much more likely to miss your appointment. But the second thing you're seeing is that as you start to get older, you start to turn up to more appointments and you go to more appointments until you hit the age of 75. And then what we started to notice was that that gap started to widen again. So there's another clinical risk as to why those patients are not turning up. When we looked at the data, we found 1% of patients who were booked and were high risk of DNA were accessing 6.3% of our outpatient capacity. What does that mean on a national basis? That's 6 million patients that are waiting for outpatient appointments at the moment. That's 6 million appointments that are being accessed by just 1%. And when you look at the elderly populations over the age of 75, we see that they make a proportion of about half of these. So what we started to do there was something slightly different. When I was a frailty reg, we used to deliver reactive comprehensive geriatric assessments, which is gold standard treatment. The reason why we would do that in the emergency room is because we knew that it would limit the amount of days that those patients would stay and improve their outcomes. But we really struggle to deliver that in a proactive way. So if we know that someone's frail in the community, how do we deliver that in a cost-effective way? And so what we've been able to do is identify those patients, validate that they're frail, but also start on those patients that if we just ask them as well, what matters most from your outpatient appointments? Do you need to come 23 times a year to the hospital? And do you need to see an orthopedic surgeon if you're in the last 1,000 days of your life and we will never operate on you? And it's not what matters most to you. Do you need to see a cardiologist when we're stopping your blood pressure medications, and actually we're managing your care from now on. And in there, we found a way to deliver proactive care in a cost-effective way. And what we've started to show is a 19-to-1 benefit cost ratio by just reducing those appointments from that current sort of pool into half of that. About 2% release in outpatient capacity, but also importantly, the benefits of proactive care in terms of reduction in GP call-outs, ED attendances, social care call-outs, as well as sort of improved patient experiences as well. We've had the first 50 go through, and just to give you a quick overview as to what that's happened. 25 of those patients all were invited to clinic. All of them had a frailty score over 5. In fact, the majority had a frailty score of over 6. Sadly, 3 had deceased by the time that we'd managed to engage with them. 10 of them had declined, and the reason why was because they were so unwell they needed reactive services. They weren't suitable for proactive care. And actually 13 have not answered despite 3 attempts. So there's another question as to what's going on there and should we start to engage with more community services. So that's a little bit about us, and yeah, really grateful for the chance and the opportunity to share this with you.
Amazing. Under 5 as well. Amazing. Go and have a seat. Look at that. Right. Now you're in treats. So when did I first meet you, Bernadette? I think we spoke before. Let me turn my time off because it's going to buzz. I think we spoke or emailed. Yeah, I wanted to meet. I was I can't remember if I was at NHS England then or not. It might have been before I started, and this company had approached me with a digitalization of a urine dipstick. You know, you dip this chemical strip in urine and then you wait for 30 seconds, 60 seconds, 90 seconds and look at how the colours change on the chart to try and work out if they've got red cells or white cells or an infection or other things I don't understand on it. And they wanted to digitise it. And I was looking around for people who not just were experts in this area, but people who will put that into practice. I can't remember how we were connected. And I sent it to you, and you were just amazing in that advice. And then after that, we started the Entrepreneur Programme, and we met again. So look, I'm not going to say any more, other than I'm your biggest fan, Bernadette. So look, now you are in for a real treat.
Thank you. Well, I might have to put my glasses on halfway through because I'm not sure I can see down to the slides there. But so I'm, as a consultant nurse with over 25 years of neuro experience, I've reached a point in my career where I could have left NHS neurology arena completely. And honestly, if it wasn't for the CE programme, I probably would have done that. And the programme has really given me an opportunity to test new ideas and to have mentorship, which is probably the most challenging mentorship I've ever had, which is really important. So it's real adult, proper, robust conversations and signposting to lots of opportunities, and a real privilege to work with other people on this programme. I mean, it is a fantastic group of the most warm, generous group of colleagues you can ever work with. So if there's anyone in the room that's not sure if this programme is for you or anyone online, I would just say, think again. This could be one of the best things that you'd ever do. And if you're working in the arena of dementia and have the bonus of being able to do it with the Alzheimer Society on this new programme, even better still. So please go for it. So instead of disappearing out of the NHS and just sort of losing that experience, which lots and lots of people do, I have stayed in I've created an honorary nurse consultancy capacity and I've been working with colleagues across the systems to create new care for people with conditions like multiple sclerosis, Parkinson's and dementia. So that's me. So the driver for change is this, and there's been lots and lots of audits around about the impact of urinary tract infections in diseases like multiple sclerosis, Parkinson's, and dementia. Now, urinary tract infections are not that complex, yet if you happen to have a long-term neurological disease, they have massive impacts. And so you can see some of the numbers here, and these audits have been repeated year after year, about the unplanned admissions for these patient groups that end up in emergency departments. And that's despite the fact that we know that there's fantastic services in place and lots of good teams, but there seems to be a lot of fragmentation, and some of the problems are out of hours. And there's also something around the soft signs that come up, that those of you in neurology will know, and in dementia, that people will know that there's behaviour changes. Or sometimes someone with MS may say, do you know what, I know when I'm getting a urinary tract infection, the first thing that happens, I get a terrible nerve pain in my fingers. And that's my UTI. But of course, that's not textbook. So, you know, and unless we listen to people, we don't really know. So people feel that their soft signs are dismissed. Lots of delays in time to treat. Using generic antibiotics. These are all the problems in the system. So I'd already worked with colleagues to create a digital care pathway for MS, but we knew that it worked. We linked it over to 111, so you had an anticipatory care plan, and we knew that people were living with MS and their families liked it, and we knew that it's avoided emergency departments. But we also knew it could be better. And the question was, could it be also improved, but could it also be useful for people with Parkinson's and people with dementia? And because of the growth in me as a person being on the Clinical Entrepreneur Programme, I had the confidence to apply into the SPRI. And within that confidence, I was able to successfully get grant funding for a phase 1 to really explore that question further, and then in phase 2 to develop solutions and take them out and test them. So really what we're doing is creating some new care pathways, digital solutions that were fit for purpose. So in phase 1, we asked, could the current model be improved for people with MS? Would this model be helpful for people with Parkinson's, dementia? And would an app be helpful to manage UTIs for all of this patient group? These were the questions we asked. And we wanted to start with real deep expertise. And so we did that by making sure that in our team that we actively and selectively recruited real experts by experience, real people living with these conditions, not the numerous scientists who applied saying, I have an interest in. We wanted to know you had to have real life experience. And so these people joined our team, and we had a core group of experts by experience on our team, and they made sure that everything we were doing was relevant, and they kept us in check. And they did lots and lots of things. All our information packs, advocates for our interviewees, there were buddies to people who were being interviewed, they co-designed prototypes, they tested things, they helped us write our grants, and they made sure that all of those key points that were coming out of the interviews and the motivations kept us on track. And that's really important, because when you're in the digital world, there's a lot of focus on actually thinking about the product and not about the need. So having real experts by experience kept us on our toes and kept us in straight to create something that's fit for purpose. And we did that because one of the groups that we worked with and partnered with is Nexer. And Nexer are really experts in co-design and listening to people's stories, and they have expertise in particular around cognitive, physical and sensory motor impairments. And they helped us to be inclusive and helped us to make sure that we were asking the right questions and that people were being listened to. And we had a real philosophy that we would leave no one behind. And that was incredibly important to our value set. And an example of that was we were speaking to someone who was in her 80s, and she said, I'm the carer for my husband. He's in his 90s. I'm very confident in using a digital thermometer and putting on an oxygen probe. But you know what? I'm never going to have a smartphone. I'm never going to use an app. And you know what? I'll be using my landline. So can you create that pathway to make sure that my husband's care plan can be seen? And yes, of course we can. So it's about leaving no one behind. And also, of course, when you've got physical sensory impairment, making sure that what happens if someone's deaf and they want to use these programs? Are we actually linked into the BSL and have sign language things? How are we actually going to have proper face recognition, biometrics that will make these products fit for purpose to be used? So the co-design was key to everything we did. So we ended up with 2 products, one for multiple sclerosis and one for people with Parkinson's and dementia. And of course, UTIs behave very differently in those cohorts. And with multiple sclerosis, the groups were younger, able to self-manage, identify, and they don't have that fast deterioration. So with Parkinson's and dementia, that was really different. The stories people told were there's lots and lots of soft signs, people's behaviors changing, someone maybe fiddling their hair, doing things that were just different. And also that the time window is really, really short. You can deteriorate really quickly. Our clinicians said that in our clinical advisory group, that we wouldn't be happy to be trying to make a call on someone remotely without knowing what their vital signs were. We'd really need to know some more things. So we wouldn't want to be doing remote calls and making ruling out neurosepsis or differential diagnosis without it being interlinked to some sort of system that can tell me blood pressure, pulse, and other things. And so we ended up creating a solution that has these components. We have anticipatory care plans that are bespoke and actually recognise the soft signs. They're personalised, and we have rescue antibiotics. We now only have a 3-hour window at this stage for this patient group. But we didn't say, oh, you happen to live in Barnet, so therefore, you're going to just have whatever generic antibiotic is. We worked with GPs, we looked at those individuals' response and where they were resistant and give them anticipatory rescue antibiotics. We give people personalised QR label urine samples that they had in their own rooms. That we were now talking about doing this in a nursing home environment because we wanted to test it in the safest way possible. We linked our pathway over to expert clinical triage people attached over to an NHS out-of-hours system in 111s, integrated to the remote new score system, linked to the 24-hour courier microscopy that can give results in 48 hours, and then being able to switch to bespoke antibiotics when results come in, and follow-up care is required. So what it looks like is that we can put this on the tablet in the nursing homes. So we tried this in 3 nursing homes in central London. 2 were residential care homes and 1 was in a nursing home as such. So the person thinks, oh, Bernie, I think she might be having a urinary tract infection. Something's changing. I've noticed some soft signs. Can go to the tablet, check in onto the pathway. It asks them to go to the Wizan blue box, take the temperature, take blood pressure, do this. It can plug into any digital remote. These happen to be the one we use in North Central London. And then they can activate the courier to come and collect the sample as and when a sample is ready. It's not going to be instant, as we know, but they're speaking to a clinician straight within that hour. Someone is saying, oh, hi, you're worried about that person. And then they can say to that person, we've got that bespoke rescue antibiotics. Let's start that. And that's important because if the carers are not trained nurses, they can't actually start a rescue antibiotic. This way you can push that and say, start that rescue antibiotic, and you know that we're here 24/7 if you need us in between. And then, of course, in day 3, 48 hours later, we get the result, and then we can look at that and say, that antibiotic isn't going to work, we need to switch now. And always follow up at the end of the course. So in the 6 months that we tried this in the 3 homes, 115 residents registered for it. The care pathway was activated 47 times in that time. And the time to speak to a clinician was 63 minutes. The new scores, which are the early warning scores, showed that they were moderate, so people were picking these things up early. The staff reported some of these soft signs, but also UTI symptoms. And then we had independent health economics looking at that. They said it was quicker time to treat and cost saving, and would be incredibly good value for the NHS if we took this up at scale. And then most importantly, what's it like for individuals living with dementia in those homes? Well, one person had to go to ED with a non-UTI symptom, but 41 had improved health overall on a proxy EQ5D score pre and post. 5 remained stable, so no deterioration. So these people did not need to go to emergency departments. And in the nursing homes before that, they would have an average of maybe 3 out of each home turning up in emergency departments. And this is some feedback from the staff saying that you know, this is about getting faster treatment, preventing hospital admission, and that people can actually become ill really quickly and goes into your sepsis. And now that people don't have to worry, and they've got something anticipatory. It's really exciting, some of this work. I think we look forward to doing more on this programme, and I think there's glimpses to the future. But imagine a future, the next step, and I'm so excited that Shula's here and Newfound, they're going to be talking next, because in the future we're going to have things like anticipatory care plans with, you know, that a person will have their care plan in their pocket. Is someone unwell, do that. But guess what? We're going to have point of care, aren't we? We'll have point of care machines in and around the communities, and then we'll be able to get an answer really quickly and get people on treatment. So we're going to be going from days to hours to minutes. How exciting is that? And I would just like to say thank you all for listening. Thank you to the Clinical Entrepreneur Programme, to my board, the Clinical Advisory Board are amazing, all my partners and mentors, I mean my official partners, and people with families living with MS, Parkinson's, and dementia, and everyone who supported the work. So thank you.
Thank you, Bernadette. I completely missed it when you said thank you to all my partners, and then thought, no, I didn't want to thank all of them. That's the people I work with. Yeah. So Bernadette used to have this little saying where she would say, you don't have to raise £1 million to change 1 million lives. But then I said, Bernadette, you've just won that £1 million SBRI programme. You can't say that anymore. You've raised 1 million. So why shouldn't we be ambitious? Why shouldn't we say, come on, this is the 21st century, 3 days to tell what bug is in someone's urine infection? Are you kidding me? Why don't we focus on that? The world hasn't done that, but our next clinical entrepreneur has. Shula, do you want to come forward? I don't know if the rucksack is a prop or what, we'll see.
Good evening, everyone. Hi, I'm Shula. I'm a doctor and the next slide, co-founder of Rapidx Bio. Before I start, I just want to say a quick thanks to firstly the clinical entrepreneurs team, Tony, Polly, and the entire program as well, because we've benefited a lot over the last 2 years, both in terms of networking, advice, and also just getting the right partners as well. For example, Bernadette. So Bernie and I have been sort of collaborating since the last year, and also thank you very much for pointing us towards the direction of your problem, which has given us the energy to go towards UTI as a first target. And I'll just talk a bit more about how our technology actually relates to that now. So the goal of Rapidx is to bring patients from symptom to treatment in minutes for infectious diseases. And we've built a very novel technique to do exactly that. So firstly, just want to reiterate the bigger problem. So think of this as the baseline problem if you didn't have dementia. And that's the problem of infectious diseases. 1.1 billion people are diagnosed with microbial diseases like urinary tract infections, STDs, respiratory infections every year. And right now, 8 days is the average time it takes from symptom to treatment. That's partly because of long GP wait times. And the other bits are because the actual gold standard tests take way too long and they're limited in labs. What this leads to is 8.7 million avoidable deaths every year and 140 million health complications. Now, that was the baseline. What does it look like for dementia patients? Well, I can even remember as a medical student, like back in my sort of geriatric placements, I sort of remember a patient very vividly where people just didn't know what she had. Some people thought she was psychotic, some people thought she was delirious, some people thought she has dementia. No one knows. And that's very often the case when you have patients who are frail, old, demented. Whenever they get the slightest infection or the slightest perturbance to their normal activities, that affects their mental capacity. And it makes them very, very difficult to treat. And it means they get treatment like much later because they can't communicate well. And it means that they become confused, they become someone who's not their usual selves. So their carers aren't able to communicate with them, aren't able to understand their needs. So it really brings to light this problem that requires some form of screening that's not just communication-based to solve. The problem is the tests at the moment are quite flawed. The diagnostic industry is a bit broken. You've either got point-of-care tests like the dipstick, which tells you, you might have a bacteria. And then it begs the question of, so what? What do you do about it? Or you can have more gold standard tests that are locked away behind laboratories. These might include PCR for viruses or microbial culture for bacteria. And the cultures typically take between 3 to 7 days just to return the result. By the time that comes back, it's typically useless because the patient's either recovered, if in fortunate cases, or in unfortunate cases, we don't even need to talk about that. So the ideal solution is to combine the convenience of the former with the performance of the latter. And that's exactly what we built. So we built a rapid gold standard testing, which uses this technique called plasmonic PCR. It essentially carries out the same sort of COVID type PCR, but in 10 minutes using lasers and nanoparticles. And we're able to do this without a lab, without any processing. You put the urine in and 10 minutes later, we can tell you what bacteria is in there and as of today, which antibiotic you can use. So I literally went to Stevenage this morning to pick up some multi-drug resistant bacteria from a friend who works in a lab there. Brought it back to my lab in Cambridge, and we tested and found ESBL resistant of E. coli in 10 minutes. So that basically means beta-lactamase resistance. Something that took them at least 4 days to find out took us 10 minutes. So just wanted to quickly show a demo of the device working. So that would be what a sample might look like. Tiny tube, put it into the device. Wait for it. And we usually have like a interface that shows you thermocycling, which is the PCR. And at the top, there's like a signal line, which would go up in the presence of the target we're looking for. In this case, we were looking for E. coli specifically. And that was programmed through the chemistry used in the reaction. So we've since, made the device a lot more portable, user-friendly. It used to look like that, and now it kind of looks like this. And fortunately, I've actually brought the device with me. So if anyone's interested, you can come up later or find me later and take a look at it. So there it is. The world's fastest portable PCR machine. Fits into a bag like a lunchbox, and you can run 2 samples at once. Powered by a phone charger, like USB-C standard plug and play. Almost there. Yeah, so the idea is we're also in the phase of converting the signals, which is more for us and scientists, into a display on an app for clinicians or carers, so they can actually see for a UTI, that's the pathogen, that's the quantity of it, because E. coli is present in most elderly people. You need to know whether it's in an abnormally high volume or not. And then you can see, we tested for these genes for antimicrobial resistance, it works on. So that would mean that maybe quinolones would work, maybe penicillin wouldn't, that sort of thing. And the goal is to essentially bring patients from symptom to treatment in 30 minutes. And that symptom bit could be anywhere. You've seen the device, it's very portable. That could be in a hospital, just like it could be in a pharmacy or a care home. And it can be operated on not just by trained staff, but technically by anyone. And we're working towards that, even on the sample collection side. So we're going to design a sample collection kits that would integrate directly with the box. So you pee into a cup, and then that cup is already specially designed to plug straight in. That's more of a competitor analysis, but I'll just gloss over it very quickly. But essentially, we're doing this because we haven't found anyone else who's able to solve the problem in that time frame with that accuracy and at an efficient cost. So just wanted to quickly give a shout out to my co-founder Nippon, who's just sat at the back. So Nippon and I basically co-founded this back in 2023, I believe. Sort of him as a physics PhD and me as a doctor. And also just want to quickly thank my team as well. We've sort of grown a fair bit over the years, and it's all thanks to them that we've been able to get to this point. And I think, yeah, and also our advisors, of course. We've had some advisors that's been advising us very directly on building this product. So once again, without their support, we couldn't have actually made it to this point with that sort of clinical accuracy that we've been able to get. And yeah, that's sort of a picture of us when we're not busy in the lab, just hammering away at this thing, which is 95% of the time. Yeah, I think that's it. Yes, of course, we had a bit more. Also, just want to give thanks to all the support that we've had as well in terms of funding bodies like Innovator UK and other UKRI bodies, as well as our investors who supported us from the very start. And yes, we also have other potential use cases. So this doesn't just stop with UTIs. We also want to be looking at other samples in the future. And it doesn't have to be limited to humans either. So this thing could honestly go on and on and on in terms of all the different problems it can start to solve, not just in healthcare, but for the whole world, whether that's the farming industry, the pet industry, the ecology industry, or just all the other problems that we see in the hospitals. Yeah, and that's finally the end.
Stay there, don't go away. I'm just trying to remember the last time I actively went to see a friend who gave me a multi-resistant bacterial infection. I can't think of a friend after that, but what friends you had? They're remarkable. There we are. Yes, right. Look, so let's let's everyone all of our pictures. And Eric, do you want to come up? And Simon, do you want to come up? We'll just stand at the front. So I don't know if any questions have come through online. If there are any, please can't do it. So I don't know. Come on, Ben, come forward. Don't be shy. Tamsin, do you want to come up and join us as well? There's no wrong or right questions. I have no idea what they're going to say. But if you've got anything you'd like to ask them about anything they've said, either individually about their technologies or about their experiences or about the program, you can ask. And if anyone has got anything online as well, you're welcome to type something in the chat and ask. You don't have to have any questions. I'm quite happy because I'm going to need to do a wrap up. I'm going to get some food as well. But I'm going to, while you're thinking about that, Eric, I'm going to ask you first. What do you think of what you've seen?
I think it's amazing. I haven't had a UTI, so I'm now expecting. People haven't never get time. But yeah, that's true. It's just what we want, what we're hoping to do in the innovation department of the Alzheimer Society already. It's been great working with your own huge team.
Does it give you hope?
I'm a bit old for hope.
I don't think you are actually. Isn't that amazing? We could do things differently, couldn't we?
Absolutely. Differently and better and more cheaper.
And do you know what I think this will unlock? I think this will unlock more research. Okay, because these are applications that are ready to go to make differences. And you know, people think, have to go into dementia research. I'm going to do molecular biology in a lab, looking down a microscope at nerve cells growing and trying to pipette something onto it to see if it makes a difference. That's not what it's about. This is frontline innovation, and I think that will multiply the research. Simon, what have you thought about this lot this evening?
I mean, it's all been fantastic. Like the amount of, I guess, innovation specifically in dementia, but things that could have like huge impact on dementia where they're broader is great. It's why we partnered with the Clinical Entrepreneur Programme, because we know how good the support is. And we're really, really excited to get our own dementia cohort kind of formed and up and running.
I think that's really exciting. Yeah, good. Any questions? Yeah, we've got one. Adrian, let me come back. Do you want to say who you are and what you do?
Thank you, Tony. Adrian Hayter. I'm a GP and I work for the Royal College of GPs as their medical director for clinical policy. And what an amazing group of entrepreneurs, really kind of pushing the boundaries of kind of care. One of the things that kind of struck me when you were all talking was this move into the community for all the work that you're doing, really kind of this push into what's happening, you know, close to people's homes, in people's homes, and actually that shift which is happening, which is part of the long-term kind of plan, if you like, from NHS England. The other thing that struck me also was kind of on a recent visit, I went to Singapore to look at some of their work over there. And I came across an amazing piece of work, which was a living lab within a dementia-friendly community. So what my question is really kind of, by collaborating, working together, how can we kind of push the boundaries of the work that you're doing so that you're not, and you've really started to kind of form some of those networks, Bernadette, and you know, you've started to form that. But can you imagine if there were 10 programs together, 20 programs together, in a living lab situation, what we could actually then prove in terms of how we could meet some of the criteria that Tony set out in terms of innovation and what happens. Because I think we're so used to working in silos that we never get to that place. But actually, I think there's some synergistic effect which could happen.
Was there a question, Adrian?
So it's really about kind of the question you're getting to Simon around kind of the work that you're doing in Alzheimer's UK and thinking more around that that kind of living lab situation and whether that's part of your plans.
Are you offering the Royal College of General Practice partner with Alzheimer's Society? I'm just checking. Or were you just asking for money? Let's see what's like.
Yeah, I mean, that's definitely the direction that we want to go in. Like, we obviously have kind of an unbelievable access to people with dementia through the services that we run. So we have the opportunity to work closely with people on, as we have through all of our innovation work, and co-producing solutions, making sure that people are available to kind of stress test products and help people with product development through our accelerator program, through the Knowledge Prize on Dementia. We definitely want to get to that position where, yeah, we have a kind of living lab model that allows, you know, all of the different brilliant innovations within dementia to be kind of tested on an ongoing basis with the support of our service staff. One step at a time for us, I think.
Cool, thank you. Eric, do you want to say something?
I just happened to have started working on a project in Edinburgh, where the whole of the Tayside health region is working towards community health care in order to do exactly the sorts of things that have just been said here today. So I'm glad you mentioned the community bit, which is community health care could also do anything we're trying to.
Yeah, I like. Anyone else want to comment on collaboratively? Well, it's a good idea, isn't it? Bringing a big group together around a common, like your longitude prize, is kind of representative. A couple more hands going up. Yep.
I know someone else has their hand up.
Well, that's right. Go. You have to say who you are and what you do. It's going to be networking after this.
I'm Sasha. I'm the customer success and implementation lead at the medical doctor by background. Was a GP training for a wee while. Sadly, didn't finish GP training, but actually worked in Tayside as well. So that's interesting. But my question was to you, Tony. It kind of spins off of what Adrian said around collaborative working. I'm not one of the clinical entrepreneurs, but Ben is, and I've been to one of your events before. And I was literally thinking the same thing. I'm like, there's so many really amazing innovations and pieces of work that lots of these clinical entrepreneurs are doing. And I guess my question is, how often have partnerships come out of those? So like how many clinical entrepreneur companies or startups have then gone on to become partners? And is there an opportunity as a clinical entrepreneur programme to sort of encourage, foster that? Because a lot of the work kind of interlinks, and I think a lot of these ideas could enhance each other and could be trialled in like maybe the same region, same area. Just food for thought. It'd be interesting to hear what you think on that.
Okay, I would say yes, we do it lots, and there are multiple examples. You had Deb. So, do you want to say, Deb, what quickly one or two key connections you've made because of the Entrepreneur Programme?
So I met a lady called Victoria Welsh on the next cohort after me, who is the bid lead in Somerset Foundation Trust where I work. So we put in the SBRI bid together. She now works as the project manager on the SBRI with me.
I was going to say just one, but you've got the Royal Mail link too.
Oh, and the Royal Mail, sorry. And the Royal Mail link from here as well when I did the big pitch second year after I've been in the clinical team, and that's absolutely.
Yep. So the managing director of Royal Mail Healthcare then recruited you. We know about your link. Any other with Bernadette? Any connections through the programme that have made a difference to what you're doing?
Other than Bernadette.
Other than Bernadette.
I think sort of indirectly Lucretia is an example, because we are sort of operating not so much in the same problem space, but very much in the same product state sort of space in terms of hardware for medical diagnostics. So even if it's not a direct sort of partnership, there is like a lot of extra collaborations in terms of like sharing ideas or like sharing the right sort of partners to work with.
Good.
There'll be lots of overlaps.
Well, Luke, go on. Who your few influential?
That's a great question, Sasha. Thanks so much. Yeah, I mean, like loads of you know so many of our clinical entrepreneurs.
Come on, your top three. Top three.
That's tough. Our advisors who sit on the company. So Sir David Sloman's one of our advisors. He used to be the Chief Operating Officer at NHS England. That was through the Clinical Entrepreneur Programme. Patrick Mitchell, who used to run
your whole
education
board is through the Entrepreneur Programme. Anyway, right, that's one. Advisors. What's next?
And then in terms of like businesses and similar companies, so work that we're doing with like Occo Health, with Michael, we're hoping to start with even Tamsin. Like these are all different aspects about how we start to interlink medical devices to initiate follow-ups. Diffu, that's also Tony.
All right. So we got advisors, we've got connections to other companies. One more.
And then the third one is actually investment. So actually the group that invested in us, we met on a Mandarin Oriental hotel event with investors through the clinical entrepreneur invited us onto. So we genuinely wouldn't be here without the networks that it provides. I think what it is though is you need to be there for also proactive and then go and do the work and connect them together versus it being something that is just offered and like it's a structure. So you're going to buddy up. Maybe that's something that we can start to work.
Okay, I'll stop you at 3, but I just want to make a point too. I think my university sometimes go, he's not submitting more receipts for another load of drinks that he's gone out or at another place. He raised 2.5 million of that down there, so not so bad. But what he didn't mention was he got to present to the board of NHS England. Now that's a real opportunity to start doing those things. It's one of those things we get. Links you've made through the programme.
Well, Bernie, you're kind of a bit of a star here tonight. We're all connected with you, but because of the work that Bernie's doing with UTIs, and I do a lot of work into care homes, UTI, significant changes in behaviour. So we've been looking to see whether we can collaborate, you know, in terms of supporting some of the work in care homes. And also, again, because I'm over from Northern Ireland and Harani are partners on the programme in Northern Ireland, the connections that Harani have supported me with just in terms of, you know, things like business. We've got advisors then, you know, through the Clinical Entrepreneur Programme that have introduced me to. So yeah, it's been great.
Amazing. Bernie?
Yeah, all my colleagues here, and yeah, that trip to Belfast was fantastic. We met so many people through Harani, and you know, and probably the biggest gift you gave me was my chair.
I hope you were going to say that.
Yeah. When you introduce someone who is incredibly experienced, and you know, and he's come forward, and he.
So I get to meet lots of senior leaders across the system. And you know, I always store them in the back of my mind. And I met the guy who set up the largest social enterprise delivering services for the NHS, turning over north of 50, 60 million a year in what he was doing. And he stepped down and retired as chief exec. And I just thought the connection was there. They met, and it's just not stopped since then, is it? And it's been transformative.
Yeah, absolutely.
And it's not just you lot, Tamsin. What's your greatest connection you've made, do you think?
Oh, so many, because mine's a hearing device, and so there are. It's the wider network of speech and language therapists and all of the other therapists that have helped. But also, I got a job. Yeah. It also helped my career. I mean, I did actually start. I started the programme not being able to do this. So it's extraordinary, as I found it quite amazing watching Deb as well. Deb assured me when she first started the programme she would never be able to stand up and do exactly that beautiful presentation that she just did.
Brilliant, thanks, Deb. Right, any more? I've got, they're all going. I'm going to, some people put their hands up the back first and then I'll come down. Maybe you want to.
Hi, so I'm Michael. I'm the co-founder and managing director. We built a bunch of different apps, but we'll be applying for the Clinical Entrepreneur Programme with a music therapy solution that provides therapeutic music to an entire care home for a year for the price of a therapist for a day.
I need to speak to you about something because the head of Sony Music has come to me about something linked to that, so we need to speak.
That'd be great, yeah. And this is really important. We're already in touch with Paul Reynolds from Alzheimer Society, so this is a fantastic opportunity. I'm really passionate about usability and accessibility. I think even for our core populations, we could always do better. And then you throw cognitive impairment into the mix and it becomes even more complex. So a question for Eric, really. Typically for myself, but for those that might just be embarking on their development journey, like for you and your PPIE team, what is important for you that makes a solution good when it comes to using a solution?
Basically, meeting needs. People don't identify needs as much as they might do. I think several people hinted today that there's a tendency to think about a product and then think what needs it can meet, rather than we've got this difficulty in the ward every day, whatever it is. How can we deal with it? So it's meeting needs.
I think that's a really valuable piece of advice, Eric. Thank you. Any more up here? Hello, Jim.
Thanks, Tony. I'm Jim Kelly. I'm a GP and co-founder of Training Gym. We've created a novel piece of exercise equipment for seated elderly, frail, and people who are suffering with cognitive impairment. The Clinical Entrepreneur Programme is amazing. you really do not want to hesitate if you go press that button to come to this programme. It gave me, and I'm really shy, it gave me the confidence to apply for grant funding, which was successful at the first attempt, which is unheard of, I believe. But it's given us the opportunity now where we're at the point to launch this new product. It's super low tech, but it could be a game changer for fall prevention and keep people motivated and moving while seated.
So that's very entrepreneurial. You give a hit. Question now.
Well, it's all about, I think Adrian pointed out, it's all about moving upstream. So we started as this being a post-operative rehab device. Now we know it's actually for everyone in their homes, spend long periods sat down. And really to you, Deb, I think congratulations on getting the RCGP to recognise the special interest in being involved. And Deb obviously was one of the first people ever to use our device called the Shutter. I can see you've benefited with how well you move. But really, it's about the question I have with Deb is: has she explored? Because as a GP, I see this all the time. People take their bag from the pharmacist, they take it home, and when it's left the pharmacy, there's a ton of stuff in there that they forgot that they'd ordered or that they didn't really need, and they just keep getting them. And I would say, show me my meds, Mr. Pharmacist, and I think you'd save a fortune, because once they leave that counter, those drugs are dead. They can't take them back. So I'd be saying, have you explored that?
Yes.
Let me help out.
There's a pharmacist in Dorset called Tracy Lyons who's done a lot of work on this and presented at the Pharmacy Congress quite a lot. And so with our launch of Medicines Waste Project in Somerset, there is going to be posters put up in pharmacists to encourage people to look in their bags before they leave. And we're thinking of putting pharmacy techs in the pharmacists to support people to do that initially. And you're dead right, it's another place that we need to look at, yes.
I love that. What way of being able to contribute to the environment, to the NHS, and so many things. Yeah, any more? Yes, hello. Say who you are.
Yes, I have a question, but I'll get on to who I am. So, hi, I'm Ryan. By day, I'm a senior AI engineer at Innovator, a healthcare company. But I'm also a clinical entrepreneur, and we build hyper-realistic AI patients for trainees. And one question that I have for, I guess maybe all of you is, how do you find the right key decision maker within the NHS? I think it's a question everyone has. How do you identify that?
Sorry, I shouldn't find that.
So, who wants to take how to find the right person in the NHS? What do you want to get me for?
I don't know the answer. Sorry. I've tried. I mean, I think that you do have to do due diligence and have a look around whatever region you're in and try and work out who's where if there's a pain point for that individual, can you go and come with a solution to help them do something? And that's how I've used it, what I've had to do across.
Anyone got advice on a go-to person in the NHS they use?
I'd say it is a dark art, genuinely, because it is not the same title or the same person in every single institution that you go to. So the key thing that you need to do is get your problem defined, and then think about how does that define itself inside of this environment that calls itself the NHS. You know, is it an ICS? Is it a trust? And then figure out how do you know whether that's on their priority, given that they are addressing that problem as well. It's really not simple to do. There's key things that you can do that can help, which is build networks, build people that have solved similar problems to you, and look at where innovation is sort of growing in similar areas that you're trying to address, so that you can map out or triangulate where those people might be. But I personally don't think that we're very good at being able to decide things in the NHS in general. It tends to be a consensus decision. So even if one person is the champion or the decision maker, they still look around to the whole team, and before they get a yes from every single person in that team, they don't move forward. It is a dark art.
Thank you. Well, Deb, yeah, go on.
I'm a great one for a road trip. I invite people out to come and visit people in the community with me to show them the scale of the problem and what's going on and what we can do differently. I think you do have to be persistent and have resilience as well.
Yep. Good, thank you. And I think I'd also say, of course, the Entrepreneur Programme helps connect with them. And we have something called the Insights Programme, 19 NHS trusts working together, help connect you into their system. So it's some structure. Any more questions, anyone? Yeah, covered it. Let's start behind you and then we'll come forward.
Hello, my name is Alon. I established a startup to slow down the progression of dementia. And the way to do it is by utilizing gaming technology and developing with people living with dementia, because as you mentioned, it is about understanding the needs and the problem before you decide to define the product. Coming from many years of product, I learned it very well. My question is, as someone that is an outsider, how can we collaborate in this way? How can we work together in order to bring those studies into execution?
Well, maybe I think the answer is to join the Alzheimer's Society Entrepreneur Programme, Innovator Programme. I mean, is there anyone else want to add to that? That's what you do. That's what you do. You sign up it, right? Yeah.
Hi, I'm Marion, one of the originally by background with a background also in emergency medicine. I've got interest area in this specific area in terms of frailty, but also vulnerable patients and advanced care planning. And working in at-home services as well as virtual wards, we all the issues that you've raised today are really important. So I'd love to talk to you all at the end. But the main questions I've got is for Bernadette and Shula, because UTIs is massive problems in the ED, as a community, and it affects patients so widely. So my question is, have you approached LAS crew in regards to diagnosis like UTI? Because what we find is with that home team, a lot of LAS will go to arrive see patients on scene, but they don't actually do urine testing, and often they'll refer to like an at-home service or virtual to come to visit a patient and actually test the urine and go from there. So actually it's wasting time in terms of whilst they can do the, suspect UTI, to actually prevent everything.
Okay, can you put it on an ambulance? I think is what was said. Shula, do you want to take that? Sure, you can.
You can.
Well done, too. Right, got any more questions? Any more? Did I see any more? Anywhere? No. There's one very special person. You're all very special. There's one very special person sitting at the back, who's one of our national directors at NHS England and the Department of Health, and she's one of our national directors for mental health. Hello, Shirley. How lovely is it? Do you want to tell them, because you're amazing, and you want to tell them who you are and what you do, and then say a little bit about what you think, given your role, around having a Dementia Innovators programme that brings all people together around this very important and shared thing.
Fantastic. Well, sitting here doing my emails at the back at the same time, so multitasking. Brilliant to be here. So my name is Shri Caledini. I'm a consultant psychiatrist at the Worsley, and also the Getting Right First Time, which I think most of you probably have heard of, National Clinical Lead for Rehab, which is my area of specialty. Various other roles as well. So coach senior leaders in the NHS, and I'm also on the Clinical Entrepreneur Programme for year 3. So still here, still here.
Feels like I've done you.
Absolutely, and my startup is all about thinking about employee well-being and development. And we know the challenges we have around workforce well-being in the NHS, but obviously there's a whole global issue. And that's something that we're really kind of developing a unique offer, which brings together a whole lot of evidence-based disciplines and brings that ground person into the way. It can really get to the kind of highest levels and perform well, stay in work, and what we call lineal genius, which that's a coaching element of really getting into those kind of top ways of being able to be in the workplace, live your kind of optimal life. So we've had some amazing outcomes. We're just still working to improve our kind of sales and really get into the people. And been on some amazing accelerators as well. This one, and that was accelerator. We've grown up to global, which is around London as well, going out across the world.
So in terms of thinking about should you have something collaborative to bring together dementia, I think it's brilliant. And so it's fantastic you're already all collaborating through your entrepreneur program and also to your own kind of networks. It makes absolute sense. You know, how can we collaborate, not compete, and really kind of make a bigger collaborative impact together on all lives. I think it's brilliant that you've done, and so different as well. But all kind of interconnected, and what a massive difference you're making. I'll be just hearing about some of the stuff about getting amazing people to support in terms of creating network, chairs and so on, so different kind of advisors and so on help. And well done with those brilliant grants. I mean, that's just so really hard to get, aren't they? That is absolutely brilliant. So you're all very modest, I've noticed, and you should really kind of shout more about what you're doing. I really love the fact that people weren't sure they were going to stay in medicine, or were either retiring or leaving medicine in different ways, and the fact that some of you would never stood up and talked to people in the crowd, and now look at the stuff you're doing. It's just amazing. You're brilliant, and keep it up. And if I can support you with that mental health, I'm really very happy to do so. A big chat. Well done.
Thanks very much. We never know who is going to get back. One of our nation leaders in mental health care from NHS England. Amazing. Thank you so much to all our pitchers and to our other speakers. Have a seat. So look, now we have some food next door. I'm told it's quite nice. The team always arrange things. The Dementia Innovation Programme opens for the whole month of October, pretty much. To apply at nhscp.com. Go and have a look. But the last thing I want to do is to just thank Holly and Lucy and Jenny and the ARU team for putting this together. They do such a great job. They work so hard behind the scenes. And so I just wanted to say thank you to you all. And thank you to those who've joined us online as well. And come up and say hello. We've got the place till 10, so I'm looking forward to some great conversation. Okay, thanks very much.